neonatal intensive care unit in 1969 was really just a name because we didn't have any of the equipment that we have today. In fact, a baby born weighing 1 kilogram had a 10 to maybe 15% chance of surviving. Today, that same baby has a 95+% chance of surviving. And that can be attributed to a combination of factors: technology, equipment, better knowledge, better therapeutic agents, none of which were available at the time. In 1970, 70% of units did not allow families into the unit. My mentors, Marshall Klaus and John Kennel, were the forefathers of what is now called family-centered care. And we encouraged the families to come and visit. And this was one of the first units in the country to do that. The other thing was that in the 1970s, if we needed a breathing machine, a ventilator, we had to use the adult ventilators. And they were designed to give far too much air and oxygen to the baby. The result was that we would give too much, and we would overexpand the lung, and the lung would blow out literally, and they would develop a pneumothorax, which is air on the outside of the lung, and the lung would collapse. New ventilators were built, specially designed for babies. So that was another big step forward. We also realized that the pioneers in neonatology said, these tiny babies can't feed. And in the 70s, there was a big advance with the ability to give a combination of sugar, protein, and fat intravenously called total parenteral nutrition. So there was a step forward in nutrition. There was a step forward in ventilation. At the end of the 1980s was another major step forward with the development of surfactant. The major cause of death until then was respiratory failure, and it was due to immature lungs that didn't have surfactant in them. Since 1990, surfactants have been widely available, and that resulted in an immediate decline in mortality. And so as we were able to apply these techniques of better nutrition, avoidance of infection, better respiratory support, so we were able to start saving babies who were smaller and less mature. And this has progressed till today, where we have a very sophisticated support system for these tiny babies. And the borders of viability have shifted down certainly to at least 24 weeks gestation, which is 16 weeks early. In the 1970s, we were in the era of anecdotal medicine. There wasn't enough evidence to say this is the way you should be treating this and that condition. And so we decided to write a book. And so this book, Care of the High-Risk Neonate, was one of the first textbooks in neonatology. And we were at the forefront of the group that were pushing evidence-based medicine. And the next step, what we're looking forward to with great anticipation, is personalized medicine, where a therapeutic regime is going to be tailor-made for an individual. And that is going to need the application of the human genome. so that I can do a set of studies on your DNA and know that if I give you these drugs, you're going to react poorly to it. So this is the direction that the field has got. I think that we've got our finger on the pulse, and we recognize what are the important areas, and so we deploy our troops, in other words, our faculty, to make sure that we are up to date and that we're involved in the investigations, in the development of the protocols. And if you ask me, what are you most proud of? It's not the few thousand patients that I took care of. It's the people that I trained, who in turn train the next generation. And so my academic children train my academic grandchildren. This is what is going to keep the field up to date and continue to advance the field.